So welcome to another video, this one about upper GI imaging. Here you can see the antrum of the stomach. It is relatively distended and there are features suggestive of atrophy. So you can clearly see the extensive fibrosis in the background. That's the area, the light areas, which are surrounded by the more vascular areas that might be standard. So if we just go and have a look at what that looks like close up, here you can see lots of almost branching fibrosis in the background of the mucosa of the stomach. And this is more pronounced if we turn on virtual chrome endoscopy. So probably here you also have islands of intestinal metaplasia, so that will be this here, like now in the center of the screen, in amongst the atrophy around the outside. And these are many, many clonal entities which all develop on their own. So this is very severe atrophy of the gastric antrum. And why is this important? Well, this is a risk factor for developing cancer, gastric cancer. And actually, if we look around this stomach and ignore the clip for a minute, we can just expand up the rest of the stomach. Let's go back to white light for a second. And actually we see here that in the body, as opposed to the antrum, the folds are relatively preserved. So if we just go more and more up in here, you really have to pull up, and I'm pushing the insufflation the whole time. The patient is deeply sedated, but you can see how much better visualization we can get if we just sit on the insufflation. Of course, you do have to have a relatively competent sphincter to allow that to happen, but if we just let it expand, we get a much better view than that collapsed view that we had before. Maybe we do see that it's slightly featureless, this antrum as well. But there are preserved rugae, particularly actually on the greater curve. So left greater curve, right, or 3 o'clock now, lesser curve. And then we come up and we have to have a good look around, and you see there's still not ideal preparation of the mucosa. There's a little skin of something there, so we would maybe miss something under here. And the reason why that's important is because these patients are at risk of flat lesions, really. So patients with atrophic gastritis and significant intestinal metaplasia are at risk of very flat things being missed. So we must take structured views, and here you can see a view which encompasses greater curve left, lesser curve right. The whole thing is distended. We should take a standard set of images here and obviously also a standard set of biopsies. But anyway, the interesting thing about this case is that here is a scar. So this patient was having their surveillance, and actually they've got two problems. They've got Barrett's esophagus and what is probably antrum predominant, but maybe also including the body, atrophic gastritis with intestinal metaplasia. And there was detected here a lesion before. If you go and look at the upper GI course, I think that maybe the second day, you'll find this lesion there and how we characterize it. But it was on the angulus, on the incisura. And this goes to highlight that these are very difficult to see. We spent a lot of time looking before we saw this lesion, and this patient had a lot of endoscopy before this lesion was detected. So message number one, these patients are at risk of early gastric cancer, and if you find it early, message number two, you can completely resect it with an endoscopic method and get a cure, because this is now the scar, and I think we are maybe 6 months out from the resection. And we see nothing in the scar. We see a clip, which we should remove, and this was used to partially close part of the defect. These do tend to stay on for quite a long time. Maybe they can stay on for up to 12 months before they fall off spontaneously. But what we see here is, if we just go up to it and freeze the image, no areas of disordered pattern within this scar. Now you might say, well, there's a lot of hematine on there, it's not very clean. Okay, we can clean it, but the risk you have if you make that assessment before you clean, and maybe we can get a little bit more water jet, is that you disrupt the pattern. So you should only do that afterwards, potentially. Okay, and we have another look now, and we can see that this scar is entirely regular in structure, and that everything's kind of coming together in the middle of it. Better is that we use virtual chrome endoscopy to investigate behind it and to look behind the clip. So here you see this bunched up hypertrophic mucosa of the scar, a clip buried into it. It doesn't tend to produce the clip artifact pattern that you get in the duodenum and in the colon, but yeah, you can see it a little bit, I guess, humped up mucosa around the clip, and on the back also completely regular pattern. So this scar is, for me, endoscopically clear of recurrence, although we will take some biopsy sampling to make sure that it is clear. And of course, you must look and interrogate the scar after you've done a resection in the stomach of an early gastric cancer. But what you also must do is look at the rest of the stomach, because we know that about 10% of these patients have a metacranous lesion. That's a lesion which is detected after the procedure of the ESD, and which is also another relevant oncologic lesion, as in another cancer. So we must look carefully, and this stomach is of course high risk. We've already had one cancer in it, so we must now take those standardized photos that, as we've described in multiple other videos. And I would suggest that you go and have a look at one of the specific videos on standardized photo assessment and photo documentation of a stomach, or our upper GI course that we did last year, to have a look and find that. So we'll take some sampling of that now. Removing the clip I think is unnecessary if we sample around it. And these patients need to enter structured surveillance, of course, if they had cancer, with imaging, certainly at 6 months, but also structured surveillance, endoscopic surveillance of their stomach, in this case at 6 and then 18 months after the original resection. Okay. Thanks very much for watching this video.